Welcome back to the AI Ready Doctor. Today we're diving deep into the ICU, a place of rapid decisions, intense complexity, and now increasing collaboration with AI. This isn't about replacing clinical judgment, it's about refining it, enhancing insight, and transforming the way clinicians think. Dr. Bencheqroun is here to unpack how specific platforms like Viz.ai, Open Evidence, and others are reshaping not just workflows, but the clinician's mindset. Let's explore these groundbreaking tools together.
Thank you, Ibrahim. Let's go ahead and do so. I think so far what we have discussed mainly is introducing the concept and the podcast. It is about AI literacy. It is about AI fluency in medicine. We're already saying we need more heart, more humanity in medicine, and now you're asking me to introduce something that has artificial in its name. It's because I want to keep the heart into our medical practice and our humanity between us and our patients. Hopefully today we will be introducing some tools so that it gives value to our listeners, but at the same time, it will introduce the next phase of our podcast, which is colleagues of mine who use AI every day, so we can actually put some names, some faces, and some case studies to our podcast.
Love it, Dr. B, bringing down the human experience into our artificial intelligence medical talk. So let's start with the basics. Viz.ai scans imaging and flags strokes. Open Evidence answers clinical questions like it's on rounds with you. Are these tools really shifting how ICU teams approach diagnostics, or just speeds up things with a techie shine?
When it comes to tech, a lot of us think that it doesn't jive with medical because there's a human at the other side. There's a bit of what Hollywood has ingrained in us, which is that Star Trek scanner that you can pass over somebody and suddenly just gives you everything that you need. It isn't quite that, but it might be taking a page out of that. When we think about Viz.ai, where it has shined in medicine is in the neurocritical care unit, which is part of my practice. What does it mean? You have someone who comes with a stroke or with a bleed, and they show up at the door of the emergency room. And so when you look at time is brain, time is of the essence. The longer you wait for something, the more brain tissue that you may be losing. Therefore, the quicker you get into a knowledge that would establish a therapy, the better. And what do we see when someone has a potential stroke, whether it's a bleed or an actual blockage? Both of these will cause you to have neurological symptoms, and so you are whisked into the CAT scan. The CAT scan is taking a picture. You still need someone to put everything aside and give their full attention to that CAT scan. If there is a prior CAT scan for that patient, to compare them, to come up with an interpretation and give a diagnosis that then is channeled through the CAT scan software into another human, which will then make a decision about it. Now, there isn't one human only. There is myself, the neurointensivist, there is the neurologist, there is potentially the neurosurgeon, there is the neuroradiologist, and then there is the neurohospitalist or the neuroemergency room doctor. These are all people that are together working for that patient. I do not want to dismiss that there is a pharmacist, a nurse, a transport person, a phlebotomist that's going to run the labs, the EKG person, the family as well. So this is a team making that decision. So if we can cut some time between those stations towards that decision, it would benefit the patient. Viz.ai maps out this and brings that CAT scan results quicker by having an AI veneer to at least do a first pass. And why instead of just a human? Because it actually augments that human. Maybe they'll take a look at certain images and details to actually highlight to that human who's going to interpret it. So it's almost like a Formula One pit crew for the stroke scan. It gets the wheels on faster. The real price is not to have any loose ends. So when it comes to that human, they tie up all of the loose ends and put everything together. Yes, fast is cute, but you have to have clarity. That's what's going to save the patient. So that's where it fits. So this is one example where AI actually augments the human.
How differently do newer clinicians who grew up in a tech-first world integrate and trust these AI tools compared to more seasoned clinicians? Can this generational difference impact patient care?
Well, it's interesting because we are seeing a bit of a generational sort of tapestry. And I should be careful because tapestry is a word that AI loves. So when you hear someone read it, you're like, well, have they had AI write this for them? Not quite. A lot of us that use these words before are being careful when to use them. So when you see a lot of us in healthcare, we all came to healthcare with different experiences, different generations, and we bring that flavor to our multidisciplinary teamwork for the patient. When you see somebody who is experienced, they bring that experience. But what we see the current generation, we were afraid that they're going to use AI to cheat. Turns out that they're not using it to cheat. They actually are using it alongside their learning. That is the study that came out recently about medical students and how they use AI. So this generational difference is actually a strength when it comes to medical practice. If you can see an intern or a medical student, they're quick, and you see the experienced and the seasoned of us, we may want to double click on something. We may want to check if what was given to us is real or not. Almost similar like you would, I don't know, fax something and then make a phone call. Did you receive the fax? When, in fact, when I was younger, my dad would tell me, double check on that if it's received. And I'm like, please, of course where is it going to go? The fax works that way. I know your generation doesn't trust technology. And then with experience, I started doing something similar with new technology. So there is a difference between the adoption of how it integrates. And we kind of need both. We need the younger generation to make us feel driven. Don't dismiss technology, it's here to help. And we need the experienced and seasoned ones where you say, technology fooled me once. The patient is at the end recipient of this in order for us to have a modern practice of medicine. Experience plus speed with data, that's modern medicine.
And I can see how medicine students feel more motivated to even study having these tools available to them, because it will it will speed up the process and how far you can get or how curious you can get with things. And also, I think that it makes people more capable to discern what it is that discern information in general, because we have much more of it available. So we have to be more conscious of how we use and how we choose the information that we have access to today.
There is the need for that. And we talked before about whatever technology used, you should see what's under the hood first and how it works in order to anticipate if there is anything that might, unbeknownst to you, not benefit your patient.
And I think that's one thing doctors do very well anyway, because of the nature of your career.
We had this discussion right before we started, right? We start in medical school, and the first thing you feel is the weight of the centuries of those that preceded you and how you arrived to this knowledge. And then you clear the path by doing the oath, which an oath that has been taken for centuries by people before you even existed. And that oath is we all work for that patient. And part of the burnout that we have is the fact that the system has moved away from that dyad, which is the patient and the physician together. Even Riverside FM is celebrating what I said.
That was really fun. And I think that takes me to my next question, because I was going to ask about Doximity and Ambient Scribes. And it promises less typing for clinicians and more face-to-face patient care. So that brings us back to what we were talking about, making medicine way more human-centered again.
I think what is interesting about talking about ambient AI is the fact that I mentioned in the last podcast, it went straight to the pain point, which is putting time back between you and your patient. When we had the electronic medical record promising us a lot, it didn't warn us that we will have a screen between me and my patient. It didn't warn us that the patient will start to tell us their story and we should be paying attention, and yet we were typing and telling them, I'm listening, just keep going. That does not feel like you're listening. And unfortunately, in the crunch of time, you did not have time to do both, listen and then turn your attention to a screen and summarize. So we felt robbed of the one thing we took an oath for, which is our patient. Now we had a solution that not only we had someone, which is AI, listening, we had a scribe, which was a human that was listening and taking note, but that was not at all the same as AI, because AI had reasoning with it that took away some of the chatter that made for the relationship that we had with our patient. And so for the medical student who was a scribe, they did not know what was important and what wasn't, whereas AI was trained for that. Now, the unfortunate thing, it started to take away some of that personal, but that was a feature also of what meant human. And some of the clues in the diagnosis was in those moments where they mentioned a story about their trip to, a foreign land, or when they were in a car, or when they changed houses. Those feel as if they were stories, but to us clinicians, there were clues to the diagnosis. So the ambient AI is a controversy still, but they did give us back time. Now, what Doximity did, and I want to disclose that I am a Doximity fellow, but more for learning. They don't pay me, I don't pay them. There is no specific financial retribution for this, similar to Viz.ai. I wanted this podcast to be a natural conversation like I would have with a friend, and I would tell you specific tools I use and what they do for me. I used ambient scribes. I used several. Nabla, for example. I used Freed.ai. I used Scribed. I used a variety of others. And I used also Doximity as a beta test. As of last week, they are actually releasing that scribe to a wider community. Literally 1,000 people worked on that particular scribe from Doximity, and it is for free. They want to give it for free because that Doximity is for physicians by physicians. And so what I find it to be is all the, I guess, the differences and criticism that we had for scribes, we poured into making it better. I wanted it to do it the way I wanted. So my note actually organizes it with at the bottom a summary, because I needed something that I can take and transcribe directly into a sign out sheet that doesn't miss the important stuff. I also wanted one that focuses on the ventilator settings. I wanted one that focuses on a social area where I speak to my patient about, where did they live and what did they do for living before. And I customized it that way. I wanted one that was critical care and one that was pulmonary. I wanted one that was, and so on and so forth. So that is poured into the solutions from Doximity Scribe. So that's the one I use mostly. I also wanted it to give me the ICD-10 code. So when I'm done with the conversation with my patient, it has all of this. So it saved me not just time now, it also saved me time when I am proofreading it. So that's why I mentioned the Doximity Scribe. The downside is it doesn't have some of the clinical decision guidance that others do, which is my second favorite one, Free.ai. That one has guidelines in it that we're trained in. So it gives you a little bit of, if it's a pneumonia, it already asks to do blood cultures and IV antibiotics and the duration of it and so on and so forth. But the clinical decision making is a gray area for ambient scribes, because then we start as physicians to question, is it updated? Is it true? Is it real? So some of the proofreading becomes important there, and you can't just copy and paste it in. So ambient AIs are good, but we physicians will always come in with that skepticism and say, but is it safe? And so that's where I want those to be, yes, less type in, more eye contact with my patient, but at the same time, more vigilance on the outset, which I think we can do.
And do you think that it actually reduces time? It gives you more time as a clinician, or do you have to use that time to verify?
I love this. In my newsletter, I will put the studies that I'm talking about here, but there was a study where they compared, and you can look at the limitations of that study. I'm a peer reviewer for articles, so of course I'm going to look at that. But within the limitations of the methodology of that study, in that study we found out that the time, we call it now pajama time, the pajama time, which is the time that usually should be off hours of work for your family and for yourself, a lot of studies showed that most physicians now have at least 2 hours during the week and 2 hours during the weekend, or sometimes more, that is called pajama time, dedicated to your EMR, electronic medical record. That pajama time has been given back to the physicians by ambient scribes, but has it? A lot of the physicians have shown that pajama time moved from typing notes to proofreading notes. But I question if it was long enough, if it included the learning curve of the ambient scribe, because my learning curve over 2 or 3 months, I started modulating the way I speak in order to use keywords to prompt my ambient scribe, so my proofreading time became less and less and less because of that. Also, it is AI, so of course it's going to learn from you. So it learns to become yours as you are correcting it. One of the things we do not do is, once we use AI, we don't go back and give it feedback. And there's always that thumbs up or thumbs down. And if you go in and click on thumbs up or thumbs down, it learns if you have something that you want it to learn to correct, or if it learns to, this is good, keep giving me similar.
That's very interesting. A lot of us do ignore that, the thumbs up or thumbs down, but it's part of the training that we give the tools that we're using on how we speak, on how we communicate, right? So that it becomes more accurate and more in tune to how we are.
You're using a keyword, and this is all about AI literacy. And we talked about training data set. We talked about the model itself and the algorithm. I want to introduce a new word, which is fine-tuning. Fine-tuning is when you take the tool, for example, a lot of AI tools now say they use the engine of ChatGPT. If you use Copilot, it uses ChatGPT. But is it using ChatGPT specifically? You can use the engine, but you fine-tune it to the use that you need. And so by you giving feedback to that model and to your account, you fine-tune the model for what you want it to give you, rather than generally what it has been given all users.
It would be really cool if we focus on how it is that you use scribes in a way that helps you be more accurate and reduce the verifying time. Maybe in a different episode.
I think that that's what we would like to do. In fact, my CHEST 2025 coming up in October, I have been privileged and trusted with a 90-minute AI in medicine session. And I picked my speakers very judiciously. Each one of them has their own use of AI in medicine, and they are well respected in their community, in their department. And one of the portions of that session is none other than a dear colleague of mine, and in fact my boss in one of my jobs, where she uses AI, ambient AI, in tele-ICU. And in tele-ICU, you see critically ill patients, and you see lots of them over a period of the day, and you have to speak to the family, you have to speak to the nurse, you have to speak to your consultants, you have to make sure that your notes are done, you have to make sure the billing is done, and you have to pause it if there's a code sepsis, if there is other things that are happening, an admission in the ER. In general, it can be anywhere between 15 up to 30 patients a day. And so you cannot have enough time to look at all of these patients. So what we do is ambient AI help us. And I asked to speak about specifically this ambient AI in the context of integration of hundreds of details per minute in order for you to make decisions that are life and death in critically ill patients. And all of your team, we are on average 3 to 4 physicians per patient. They look towards you for leadership in this case of a ventilated patient with 3 to 4 pressors. And is it the heart? Is it the lungs? Is it the kidneys? Is it the liver? All of them together, all of the medications, are they interacting? Should we stop something? Should we start another one? Do we change the antibiotics? And then what is the prognosis of those patients? Should we involve somebody? Do I call a surgeon? Are they stable for surgery? All of these things are very important in order to integrate. And so ambient AI become your partner in putting all of this together while you are on video in a 2-dimensional place, speaking to all of these actors in one patient, multiply that by many during one day, and then rinse and repeat every day. So we will have the ambient AI demonstrated, and that's where one of our speakers is going to be that. I also would like to, introduce the Doximity Scribe, where, again, no relationship, no financial remuneration whatsoever, just something that works for us physicians.
And I was just going to say, if there's more physicians using these tools, will these tools become smarter in terms of medicine or the medical field per se?
A friend of mine and I, his name is Vishy, interventional pulmonologist, he and I discussed, once you have a tool, like let's say, for example, we speak of ChatGPT, let's take Gemini. Once you have Gemini and you put it as the engine towards a task, let's say to review CAT scans in a hospital A, one of the states. Now that tool is local, and you are using it to perhaps augment the radiologists of that hospital, and it's getting the CAT scans of that hospital, and it's getting the feedback of the radiologists of that hospital. How are you QCing the output that is now local instead of general of Gemini? And how are you giving credit to those that are training locally that tool for that hospital? And 3, how are the upgrades to Gemini that will be integrated into that hospital locally will maybe disintegrate or help empower that training that is local? We call that the post-deployment phase. It needs maturity, basically. We focus too much on the tools themselves, but we forget that there is time factor, and there are people that are using them. And is the accuracy by which we talk about in those tools durable enough, or does it change and perhaps deteriorate with time and with usage? Or is it empowered locally only but cannot be used elsewhere? So these are conversations to be had, and that's the reason why I wanted to have this podcast, so that we can start to talk about the real thing, which is this, instead of, is AI going to replace me?
It came to mind as you were speaking. You talk about AI literacy. It's the present moment. And I wonder if there's such thing as human literacy for AI.
How to make AI literate in humans. And I can already tell you that is the basis of AI. It's training it to think. That is the basis of a neural network, to think like a human, by integrating knowledge created by humans. So there is an AI literacy in humans. The issue is AI can only make you believe that it speaks human. It recycles human knowledge. It doesn't create new knowledge. It doesn't discover new things. To a certain degree, some might say we are discovering new molecules to treat new things, but it's the human that puts together the ingredients. It's the human that puts together AI with machine learning of chemistry, with machine learning of research, in order for you to come up with the new thing that would treat pulmonary fibrosis, for example. I bring this example a lot because I'm in love with this company that has put it together to solve problems human cannot solve on their own, and augment them, and then human take it and apply it in research. I know of another company, for example, that's trying to solve the issue of all of the ventilator settings in life and death situations that affect the human health. And they are on the forefront of that. So I think that human literacy for AI is already there. AI literacy for human is what we need to work on.
And in terms of Perplexity and SciSpace, do you think these tools promote curiosity in the medical field, or it's creating more like reliance to quick answers?
So in terms of SciSpace, for example, that's one of the tools that I enjoy a lot. And the reason why I enjoy SciSpace is because it is the ChatGPT, if you wish, for research. It is the training set is for research. And so what it allows me to do, and there's plenty others, for example, you can use Site.ai. For example, you can use Consensus. For example, there are plenty of others you can use, but I choose one in order to give just one example. If I were to share my screen and demonstrate what SciSpace looks like, it allows you to search for a query. For example, I'm going to search for a query that, and you can choose deep review, high quality, or standard. Standard is a quick search and result. Deep review engages neural networks and goes into what we call a reasoning model. And we've spoken about this in previous episodes, but it takes a little longer, yet it goes deeper. What you can also do is other tools, for example, this tool, which I enjoy, you can look, for example, to upload a PDF. This is a PDF that I uploaded of my randomized control trial that I've done in outpatient COVID, where we tested a pill that is known for centuries amongst the Middle Eastern and Muslim communities, which is called the black seed oil, otherwise known as thymoquinone. And with my partners, including Dr. Kasib, we put this together in a pill that can be taken, and we tested it against placebo in patients that had COVID to see if it can reduce the time to healing. If you took this, and a lot of us that do journal club, for example, we are not necessarily savvy about biostatistics or some of the more advanced tools. You can upload this in here and you can literally start to ask questions. What is the statistical tool used in this study? And it's going to look at the PDF here and it would answer you. So the statistical used here is the SAS version 9.4. I asked this before, for example, tell me what this study is about in a few sentences. And it gives you, this study investigates the safety and efficacy of thymoquinone in outpatient SARS-2. It's randomized double-blind control. What is the statistical analysis methodology used and why? It's comprehensive and it's designed to use, here's what it did. Randomized and blinding 1-to-1 ratio, intent to treat analysis, per protocol analysis, what are the subgroups? It used the survival analysis and it used the power and sample size, how it was calculated. And what statistical tests were used? We used in this study Kaplan-Meier survival, log rank test, chi-square, t-test or Mann-Whitney U-test, and so on. So it allows you to literally chat with the PDF. It's almost like you have somebody who's well-versed in research all working with this. And the second tool that you used or that you asked me about is Perplexity. And the tool of Perplexity, why I like it, is because it uses engines that you can change from one to the other. And it gives you results with references. So I can use, for example, bring me all the articles on black seed oil in COVID tested in a rigorous scientific manner. And it will search all the internet and gives it to you with what are the sources in almost a manuscript style. Here are all the open label RCTs, the combination trials, the meta-analysis in 2023, and here they are. And you can click on them and find those. And it not only gives you this, it also gives you related questions. If you wanted to ask, they're already here for you. Systematic reviews, meta-analysis. You can literally ask, give me the closest gourmet restaurant serving Moroccan food around the San Diego area. And it will also search the internet and gives them to you with sources that you can click on in order for you to verify, along with others. Additionally, you can change that to deep research if you want to deep search something, you can use a voice, you can share screen, you can attach files in order to make your research even deeper. So Perplexity now has come up with its own browser. I'm on the waiting list. It's called Comet, and it uses AI to browse for you. We are watching a revolution in what we learned about Googling something. When you Google something, you get a list of links and you have to click on each one. This one actually gives you a summary of all of it with references of to click on those lists if you wanted to. So you save time, and now we no longer have search engine optimization. If you want to come up on searches for people that look for you, your website, your services, you actually have to create content and become expert in what you search, in what services you give, if you want to start coming up on people's searches. There is a revolution in marketing because it's no longer about Google first page.
In your experience, do physicians actually know how to use ChatGPT versus Perplexity? Or do they identify well how they differ in terms of usage? Because we've talked about how ChatGPT hallucinates. And if you were to ask him, tell me restaurants that nearby that serve Moroccan food, it could potentially come up with misinformation. But do you run the same risk with Perplexity?
Great question. And that means that you're asking for other people. I loved how you phrased it when we first started. You said, I feel like I am the voice of the public, and how can I ask questions that they might ask? What I'm asking for hallucinations is we rely on ChatGPT too much to give us answers in brainstorming with us. What Perplexity does gives you references that you can literally click on the page, and it opens the browser and you can verify that factoid before you can trust it or not trust it. That's why I feel like Perplexity might be a bit better than ChatGPT when you're researching something that you were going to Google. So I joke, I say I don't Google anymore, I Perplexity. And yes, as a disclaimer, again, I am a Perplexity business fellow. What that means is I learn from them about their tools. I don't get paid by them. I don't pay them. I don't get any financial remuneration from them. What I wanted is to be in the space where I learn deeper about this so I can bring this knowledge to everybody else in ways that they can understand. I Perplexity instead of Googling because it saves me time in digesting that information without taking away from me the possibility of fact-checking it right on there. With ChatGPT, it actually gives me the illusion that I have my answer, and it takes some researching on there to find where do they get that answer from. How can I verify that what you're telling me is true? Whenever you have, in this day and age where we don't even like to wait too much on our meal at a restaurant or our food delivery, we want things here and now. I don't want to have to look on the page for where's the source of that information. Perplexity gives it to me right away and I can click it immediately. Even Gemini, I have to search for where is that source of that answer. So I'm given something that I use on a daily basis. It has an app. You can search for it instead of Googling something. It just is so good. It has morphed all of the searches for financiers. If they want to look up a company, if they want to look up all of the investors' meetings and all of that, you can search for the stock market history. It's now got a way to search for, if you're shopping for something, you can click right away for, I upload a picture of somebody's sneakers that I saw that I loved, and it'll find them for me, and I can find it on whatever shopping website immediately. So it just is for the consumer. Whenever you skip steps for the consumer, that gets my attention.
Could you give us an example, a practical example of how you use these tools in medicine, for example, like how you use specifically, what would you use ChatGPT for, or what would you use Perplexity for, or what would you use in your day-to-day?
Something that is a common situation in a physician's life. That is, if you're in the hospital, rounds. You're rounding, the patient is in the hospital bed. You come to the patients, you ask them questions, you have your electronic medical record, you're looking at labs, and now you have to make a decision about multiple things. For example, is this a pneumonia? Is that pneumonia bacterial or not? Are the antibiotics I'm choosing the right antibiotics with the guidelines? How long are those antibiotics? Is there any interaction between that antibiotic and this particular medication? Is it safe to discharge a patient? Can I use this score or not? All of these things, and you have to do them within a short amount of time because you have 15 patients around on, plus meetings, plus you have to follow up on the decisions you made in the morning, plus you have to sign all your notes, so it goes to your team, who then uses them for discharge planning, social workers, follow-up appointments, patients' discharge documents about their visit, and so on and so forth. So for me, I found it to be very rewarding to search things at the moment by the patients. I have my computer. So for those of us that perhaps are embarrassed that the patient is going to know you're looking up stuff, that is exactly it. If you used something that can give you an answer right away, amazing. So what a lot of us are starting to use is something called open evidence. And open evidence, as opposed to others, for example, we used to use something called UpToDate. UpToDate right now, I've attended a webinar in which they're trying to integrate AI because of open evidence. It revolutionized our rounds. The ChatGPT, but trained on evidence. Everything from New England Journal to publications and so on. So open evidence has signed content agreement with JAMA and New England Journal. So you can go here and ask question, 55-year-old female presenting with diagnosed pulmonary embolism as well as upper extremity DVT. Give me the guidelines on how long to treat with oral anticoagulants. I literally just, a fictional question. It doesn't just give you an article and you have to sift through the article in terms of you trying to find out what exactly in that article applies to the patient. It actually answers you with specifics to that patient and to that question. Oral anticoagulant, 3 months, extended, indefinite, and then it gives you the actual article and the table that you can review with the reference. And then follow-up questions. Amazing. Why do I have to wait until the evening to look up something when I can look it up and I can make a decision right there and I can copy paste the reference into my medical EMR? Now whoever reads my note thinks that I am literally academic, and they're not wrong. I am. I also try to use SciSpace for the same reason. The same question, and they can give you also the same way. Sometimes I have an anticoagulant for blood clot, and the patient is there having heavy menstruations with a hemoglobin that dropped. This did not read the textbook. It is an integration of references. So you can ask open evidence, or you can ask Perplexity, or you can ask SciSpace in order for you to get a customized answer. So that's how I use it. I use it in rounds. I use it in the clinic when I see a patient and they're bringing me, they have Sjogren's disease, along with pulmonary fibrosis, along with an antibody that is only positive in rheumatoid arthritis. So Does the patient have rheumatoid arthritis related pulmonary fibrosis or Sjogren related? Does it matter? What are the treatments that I can give? Is there a treatment that is going to affect the patient negatively? Those are what we see on a daily basis. We need tools that answer that don't give us a list of articles and then we have to read them, integrate them, then come up with our answer. No one wants that.
So it can augment and also save you time, which I think that is gold. Having said all this, Dr. B, learning about all these different tools, how they apply to medicine, is there something that, one cognitive habit that you could recommend clinicians they develop immediately to thrive in the AI enhanced ICU? Like what would that habit be and why?
So the cognitive habit is use it in inconsequential real life ways. 2 is the skeptic pause. Why did it give it to me this way versus the other one gave it to me that way? And then the third and last one, is that the best you can do? Send it back, see what it's going to give it to you. This little exercise in various things will save you a lot of time for when it matters in front of your patient.
You made me think, Dr. B, also how maybe we've also been trained already by life and technology and the way we've been evolving with the easier access we've had to information. We've learned to understand what's real and what's not, or to search and search deeper to see what's true and what's not. So I think that it kind of just applies in the same way to AI, that power of discernment, especially for the clinician mind, which is already trained to be critical, to critical thinking.
You bring up an excellent point that I discuss with my residents all the time. As a physician, what makes a physician good is finding the anomaly, finding that which is abnormal so you can fix it and restore somebody to health. Where are you going to find it? In a sea of details, verbal, labs, imaging, that you spend years honing in what is normal, what is abnormal, what are the nuances, and what makes a physician even better if they can spot that anomaly when it's subtle. We call that the subtle signs before the impending doom. If somebody comes in and says to you, there's going to be an earthquake in 5 minutes, you went to school years just to give me 5 minutes heads up. But if you look at subtle signs and you give me, there's a 95% chance there will be an earthquake in 3 days. You have time to implement to reduce the damage, right? So as physicians, we spend years of knowledge and then years of experience honing that anomaly, that skepticism. Now, it doesn't make us, pleasant companions when there's fun around in real life, because who wants to have that person who always finds wrong in everything? But in our work, that's what validates us the most. And so I think there's a healthy skepticism in trusting AI. But that doesn't mean we cannot adopt it. It just means that once you adopt it, you can't have the pendulum swing the other way and over-rely on it. You still have to have a healthy skepticism of verifying the output of AI.
This has been great, Dr. B. I think it's time to close our episode and leave some information for the next one, which I'm already looking forward to.
Curiosity is infectious. Catch it here at the AI Ready Doctor podcast. And thank you for listening.
Being AI ready in the ICU is less about mastering the latest app and more about mastering a new way of clinical thinking. critical, reflective, and adaptive. If today's episode resonated with you, share it with colleagues navigating this exciting transformation. Join us next time for another deep dive into becoming AI ready. Until then, keep thinking, keep questioning, and stay AI ready.
Thank you.